This is our presentation on myasthenia gravis for NP2. Group participants include Daniel Dean, Johnny Gonzalez, Lucy Lamb, Alyssa Sanchez Palencia, Debbie Tomlinson, and Amber Wolford. Myasthenia gravis is an autoimmune disease of the neuromuscular junction in which antibodies attack acetylcholine receptors. This occurs in either gender and any ethnicity. In women, we see an onset at around approximately the age of 28, and in men, we see the onset at around approximately the age of 42. General signs and symptoms of myasthenia gravis include muscle weakness, specifically weakness of the arms and legs, difficulty swallowing, impaired speech, difficulty chewing, fatigue, shortness of breath, impaired voice and/or a change in voice. Facial signs and symptoms can include facial drooping, facial paralysis, drooping of the eyelid, and double vision. Several laboratory tests can be performed to confirm the diagnosis of myasthenia gravis, the first of which is acetylcholine receptor antibodies. This is actually the primary blood test utilized for diagnosis and provides a diagnosis in 90% of generalized MG cases. Also, too, provides a diagnosis in approximately 50% of those individuals with ocular MG. Additionally, the anti-MuSK or muscle-specific kinase antibodies test can be utilized in 50 to 70% of those individuals testing negative for the acetylcholine receptor antibody test. The anti-MuSK test actually provides the diagnosis. The third test that can be used is the anti-striated muscle antibody test. And in 80% of those individuals with MG who actually have an enlarged thymus gland and have significantly increased likelihood of having a thymoma, which actually generally is a benign tumor of the thymus, this can actually serve as the primary source of diagnosis. Several other tests can be performed when attempting to determine if there is a true diagnosis for myasthenia gravis. The first two, rheumatoid factor and cyclic citrullinated peptide antibody, are both designed to rule out or detect rheumatoid arthritis. Also, the anti-nuclear antibody test can be done to rule out any other autoimmune disorders, such as, for example, lupus. And lastly, a thyroid panel and thyroid antibodies can be performed to rule out Graves' disease, which is an autoimmune condition associated with hyperthyroidism. Several non-laboratory tests can be completed in the process of determining a diagnosis for myasthenia gravis. The first of which is the Tensilin test. This test actually is done by utilizing a drug called edrophonium, and the drug is actually given via IV to see if muscle strength improves for a few minutes after the injection. Another option for testing is the ice pack test. If a patient actually is presenting with a droopy eyelid, the physician may place a bag filled with ice on the eyelid for approximately 2 minutes and then remove it to analyze if the droopy eyelid has signs of improvement. This can actually sometimes be done instead of the Tensilin test. Also, the repetitive nerve stimulation or single fiber electromyography can be completed, and this actually evaluates neuromuscular response in a specific area. A chest CT can actually be done to detect in a large thymus gland or a thymoma. And finally, brain and eye orbit MRI can be completed. It is non-routine, but it can actually be helpful in ruling out any other eye-related symptoms that the patient may be experiencing.
A couple of ways we can manage myasthenia gravis include drug therapies, surgery, plasmapheresis, IV immunoglobulin G, and supplemental therapies. Drug therapy includes anticholinesterase agents. These medications slow the breakdown of acetylcholine at the neuromuscular junction and thereby improve neuromuscular transmission and increase muscle strength. Acetylcholine being the chemical messenger that causes muscle contraction, so the more acetylcholine, then generally resulting greater muscle strength. They are the first type of medication prescribed because it has the fewest long-term side effects and it's pretty quick acting. Although they do not directly counteract the abnormal immune system attack, they may partially or completely control the MG symptoms in some patients. Because these medications can cause stomach cramps and diarrhea, it helps if you take them with bland food like crackers, applesauce, or yogurt. A couple anticholinesterase agents include pyridostigmine and idrofomium. Pyridostigmine is available in tablet, liquid, and time-release forms. The different forms of it vary in how soon and how long they're effective. A couple side effects include diarrhea, especially at the start of treatment, increased saliva, increased sweating, and nausea. Idrofomium is primarily used as a diagnostic tool because of its short half-life, and it's part of something called the Tensilon test, which we'll talk about later in this PowerPoint. With these medications, you want to be on the lookout for a cholinergic crisis, which is an overstimulation at the neuromuscular junction due to an excess of acetylcholine. The antidote for it is atropine, and the signs and symptoms of it include diarrhea, urination, meiosis, bradycardia or possibly tachycardia, emesis, lacrimation, lethargy, and salivation. Immunosuppressants are also drug therapy that could help patients who have myasthenia gravis. So immunosuppressants, they suppress the immune system. They make one more susceptible to infections. So it would be important to avoid someone who has a contagious disease, maybe avoid crowds and have good hand hygiene. It prevents your body from producing the harmful antibodies that cause MG weakness in the first place. The most common type used is prednisone. It significantly relieves MG symptoms for a large majority of myasthenics. It's not as fast acting as the anticholinesterase, but it's faster than other immunosuppressants and it's relatively inexpensive. And it resembles natural hormones produced by the cortex of the adrenal gland. A couple side effects of prednisone include insomnia, mood changes, weight gain and fluid retention, reduced resistance to infection, increased susceptibility to diabetes, high blood pressure, osteoporosis, glaucoma and cataracts, and stomach ulcers. While taking prednisone, something to look out for would be adrenal insufficiency. When you take prednisone, it stops the body's natural production of the adrenal hormones. Prednisone therapy must not be stopped suddenly. What needs to be done is the dose must be tapered to gradually reawaken the body's natural hormones. Abruptly stopping prednisone can lead to adrenal insufficiency, and some of the signs of it include fever, fatigue, dizziness, anorexia, hypotension, dyspnea, hypoglycemia, and muscle and joint pain. Other immunosuppressant medications include tacrolimus, methotrexate, cyclophosphamide. These have side effects of increased risk of infection, loss of appetite, nausea, vomiting, increased hair growth, and hand trembling. If one of these medications can help someone who has myasthenia gravis, it can eliminate the need for prednisone or allow a lower dose of prednisone. These medications can take months to become effective, so they're slower than prednisone, and the dosages will vary from person to person. Another type of treatment for myasthenia gravis is surgery. So a thymectomy is the removal of the thymus gland. Some people who have MG develop thymomas, and generally the thymomas are benign, but in rare cases they can become malignant. Surgery is recommended for individuals with thymomas and for most patients under the age of 60 with moderate to severe generalized myasthenia. According to the National Institute of Neurological Disorders and Stroke, surgery reduces MG symptoms and may cure some people, possibly by rebalancing the immune system. This improvement, however, is unpredictable and may take several months or several years after surgery to occur. The thymus gland plays a role in myasthenia gravis, but the function is not fully understood. Scientists believe that the thymus gland may give incorrect instructions to developing immune cells, ultimately causing the immune system to attack its own cells and tissues and produce acetylcholine receptor antibodies, setting the stage for the attack on the neuromuscular transmission. Plasmapheresis is another form of treatment. It's also called a plasma exchange. It's a procedure that removes antibodies from the blood. The antibody-free blood is returned to the body along with albumin to replace some of the proteins lost in the procedure. It could possibly cause hypotension and dizziness, and an allergic reaction could possibly occur from donor products. This only provides temporary relief that lasts about 2 to 3 weeks, and it is a very expensive procedure. IV immunoglobulin G is another form of treatment. It works by binding to the antibodies that cause myasthenia gravis and removing them from circulation. Weakness will typically improve within a week of the treatment, and it will last for several weeks or months. It is very expensive, and it only provides short-term relief, and some side effects include headache and allergic reaction. And then there are also supplemental therapies. So eat healthy. Extra pounds can make it more fatiguing to get around and can aggravate a host of other disease. Exercising can boost your mood, as well as the health of the heart, brain, and cardiovascular system. Manage stress, get outdoors, and talk to others. Talking to others can combat isolation by calling friends and family or even contacting a support group.
The complications of myasthenia gravis include myasthenic crisis, hyperthyroidism or thyroid toxicosis, rheumatoid arthritis, lupus, or thymus tumors. Myasthenic crisis is a serious complication where the person experiences the inability to breathe due to weakness of the muscles that control the breathing and can lead to respiratory failure. Signs and symptoms of myasthenic crisis include difficulty breathing or speaking, pulling of the skin around neck, abdomen, and ribs, morning headaches and daytime fatigue, frequent night wakings or not feeling rested after sleep, weak cough with increased secretions, weak tongue, trouble swallowing, and/or weight loss. Hyperthyroidism and thyroid toxicosis is an excess of thyroid hormone in the body. Signs and symptoms include weight loss, nervousness, irritability, intolerance to heat, excessive sweating, shakiness, palpitations, increased bowel movements, and muscle weakness. Other signs can include rapid pulse, loss of body fat, muscle bulking, thyroid enlargement, fine tumors of the fingers, and hot, moist skin. Rheumatoid arthritis is a disease that leads to long-term inflammation of the joints and surrounding tissues and can affect other organs. Early symptoms include minor joint pain, stiffness, and fatigue. Joint symptoms can include morning stiffness of more than an hour, joints feel warm, stiff, and tender when not used, joint pain in the same joint on both sides of the body. Joints are often swollen, and over time, joints may lose range of motion and become deformed. Other symptoms are chest pain with respiration, dry eyes and mouth, eyes burning, itching, or discharge, nodules under the skin, numbness, tingling, and burning of the hands and feet, and difficulty sleeping. Lupus is an autoimmune disease whose signs and symptoms include chest pain, fatigue, fever with no apparent cause, general discomfort, uneasiness, or feeling ill, hair loss, weight loss, mouth sores, sensitivity to light, a skin rash over the cheeks and bridge of the nose, and swollen lymph nodes. Other symptoms vary depending on the part of the body that's affected. Tumors of the thymus affect approximately 15% of patients that have myasthenia gravis. Most of the tumors are benign. For the nursing diagnosis, ineffective breathing pattern related to neuromuscular weakness of the respiratory muscles and throat. The interventions include assessing for signs of activity intolerance, which can be the patient reporting greater perceived exertion, and you can monitor for respiratory status and ability to cough and breathe deeply, adequately. Dyspnea on exertion, palpitations, headaches or dizziness, or patient reports of exertion levels are all signs of activity and intolerance and can indicate decreased tissue oxygenation. Another intervention is to monitor the pulse oximeter and take note of O2 saturation of less than 92%. Be sure to monitor patients on the pulse ox at least every 4 to 6 hours. An oxygen saturation of less than 92% indicates hypoxia and may signal the need for supplemental oxygen. Also, for an intervention, you can administer an anticholinesterase medication as prescribed and maintain suction and emergency equipment at the bedside. You would suction as required due to increased bronchial secretions. The desired outcome is the patient will maintain an oxygen saturation of greater than 92% and a respiratory rate of 12 to 20 while performing activities of daily living. For the nursing diagnosis, risk for aspiration related to difficulty swallowing, you would assess cough reflex and any swallowing disorders before you administer anything by mouth, making sure that the patient can swallow prior to giving any food or medication. You would monitor the speech, mental status, and swallowing abilities to prevent aspiration. You'll be watching for any signs of aspiration and dealing with it as quickly as possible. You will also position the patient upright with his or her head slightly forward when eating and drinking. This way you can assure that the upper airway patency is protected and you reduce the risk for aspiration. The desired outcome is client is able to swallow independently without choking and able to maintain a patent airway. For the nursing diagnosis, self-care deficit related to muscle weakness and general fatigue, interventions include observing the patient's ability to perform ADLs. This shows any performance challenges and the level of assistance that the patient may require. You will also allow enough time for task performance. Do not rush the patient, and you can involve the family and significant others in care activities. You'll also observe the patient to make sure that they can perform them safely without assistance. By allowing sufficient time, you preserve the patient's energy and increase their tolerance in activities. You also can plan short activities that coincide with times of maximum strength or energy for the patient. By teaching these strategies, they learn how to manage their fatigue and conserve their energy. The desired outcome is patient is able to perform self-care activities independently and able to demonstrate ability to use adaptive devices for completion of ADLs. Other nursing interventions and outcomes include teaching the patient about the action of medications and the importance of following the prescribed regimen. It would also include signs and symptoms of myasthenic and cholinergic crisis. The patient will verbalize an understanding of the drug regimen, the action and the purpose of the drugs, side effects, and contraindications. You will teach strategies for the patient to conserve their energy, and the patient will develop coping strategies to avoid overexertion. The patient will develop a plan to avoid overexertion in daily life. If the eyes cannot close properly, instruct patient to patch or tape eyes closed for short intervals to avoid corneal damage. And the patient can then demonstrate the correct method for patching and taping the eyes.